Doug Van Uken became a medical doctor in 1990, years after he was engaged in community organizing among underserved people in Cleveland. He's been in family practice at Metro Health for more than 30 years and has been in HIV practice for that length of time as well. He founded Metro Health Pride Clinic in 2007. When he retired in 2020, he returned to work part-time providing LGBT care exclusively at Gordon Square with a focus on hormone therapy. Please welcome Dr. Van Uken.
Hi, everybody. I wish I had a way to get to know every one of you. I hope I get the chance as time goes by. I guess I should start by just a few data points that LGBT people make up 8% of the population in America. That's at 20 million adults. 4%, in other words, half of this number, supposedly according to CDC, are bisexual people. 2% are another sexual orientation, 1% transgender. I don't know if these numbers are really quite right because it seems like many people have nuances of gender, and there's a redefining of gender going on. I suppose this is pretty much public knowledge, but people now talk about non-binary. Do people know what that means, by the way? It means that the person does not say, well, I'm all male or all female. I'm not either one, and I'm someone on a spectrum of gender. And I say to myself, well, why not? We have different colors of people, we have different sizes of people. Why would we all be the same gender? I think some of it, though, is because the history of our country has driven some of these ideas from our consciousness, and it's time to reclaim them. And I respect the younger generation that is hoping to do this. There are people who have new concepts of gender and new concepts of family. When we started Pride Clinic 17 years ago or whatever, we really didn't have this idea in mind. We thought we were going to serve gay men, people with HIV, lots of sexually transmitted diseases, and we would highlight the risk of breast cancer in lesbian people, which is an important issue, and just be supportive of LGBT families that we could see were growing, and that was going to change the definition of family over time. What we didn't anticipate was the way that gender would change in our personal lives, our public lives, and how people would start talking about it differently than before. I think about the way that we would talk about things in the office. And now I'm schooled every day from young people who talk about their lives in ways that I never quite imagined. People come from different kinds of backgrounds to arrive at their perception of themselves. And there are a lot of people who struggle to do this. It's surprising how many people will talk about how they get kicked out of the house or they had to grow up with all sorts of problems. I think for the physician, this gives you a unique opportunity to reflect on how people grow and learn. It is not true that the brightest person in the room is the person with a college degree. You've probably all been in a room where somebody else comes up with the best idea on how people can get along, how we can work together as a group. This is the same thing that happens in the doctor's office when you talk to people about family. Family is still a concept I think that we all agree is important, because family is people that are close to us, people that support us, people that help us live better and move forward into the future. Well, for a lot of transgender people, family is not really as protective as you might think. You hear a lot of stories about trauma, and that trauma will include physical trauma, being forced to wear clothes of the opposite gender, being forced to use names that people don't like. There are many families in which this can be really troublesome. And so young people can grow up with a lot of conflict, bad feelings about themselves, and inability to be true to themselves. In the last 15 years, though, there have been all sorts of ways that people can live better. They can join gay straight alliances in school. They can talk to their physicians about getting hormone therapy. They can change their name. They can move away when they get the ability and start a new life free from the fetters of the biological family. I think these are pretty profound changes in our society. Trauma, whether it be beatings or belittlement or whatever, I think also informs us as to how we can learn from trauma as well. It's kind of a learning experience, but I don't think that doctors, I thought we have quite a few doctors today. I don't think doctors are really trained to look at trauma, except in a negative sort of way. Well, I've decided that one way to look at bad experiences is to celebrate the resilience of the patient who has experienced them and say, wow, your mother was an alcoholic and beat you when you were a child, and yet you still have a relationship with her. How do you do that? And then they will say something like, well, I recognize that she has had difficulties in life, and we need to keep in touch because she still loves me in her own way, even though she has these problems. Other people will say, well, my grandparents had to raise me because my parents were unable to. They had all sorts of problems. My dad was in jail, or who knows what it was. And so they live in families where they had to sort of recreate a sense of family because the one they had didn't work. Well, this requires skills. And I've decided that as a doctor, I should praise those skills. It's a lot of work to come up with a new way to build a family, somebody you talk to all the time. Maybe you live with somebody that doesn't even think you should change your gender. That's a real challenge, but a lot of people do it. And they say, well, they don't really accept me for this, but in other ways, they've helped me get an education. They loan me money to buy a car. Young people are able to see nuances of relationships in families and nuances in how to reach their goals. They're pretty clever. And I think transgender people are particularly skillful at this. As a physician, I think that we need to figure out a way to praise the patient and their efforts, and not to focus on a diagnosis of trauma or a negative diagnosis, because it won't really get us where we want to go in terms of helping the patient. So when I talk to somebody about gender and they say, well, I was, forced to wear girls' clothes, when I was young, and I hated doing that, but in the end, I didn't know what to do, but I felt ridiculous. Or they'll say, well, I wanted to play baseball with the boys, and they wouldn't let me, and I kept trying, and finally, they just told me I couldn't, and I was forced to sit down and watch the game. They told me I could be a cheerleader, but I felt to wear one of those little dresses was really terrible. And so they'll say, well, I figured out that just wasn't for me. But then they continue through junior high school, and they graduate, and as soon as they have a chance, they try to live differently. They come up with a new name. They'll come up with a new name maybe in junior high school. Instead of being Brenda, they'll be Brett, or they'll have other names that are invented that are very unique. And if you talk to people without the name they choose, well, they have a whole story about it. It's really exciting to hear people about naming themselves and becoming a new you. Transgender people really do raise themselves. It's very exciting. LGBT people, all sorts, have always done the same thing. Coming out of the closet, there are many gay men or lesbian women that come up with different names. Sometimes it's just an extension of the one they were given, and sometimes it's a new name. That's a positive thing, and I think as clinicians we should always praise that. So I like the idea that a chosen name is now in the medical record, and clinicians are encouraged to accept that along the way. All of this is a way of trying to think positively about people's negative experiences, I guess, is one way of looking at it, because the goal of every person is to survive and grow. And when they come to the doctor, instead of just sitting and listening to questions about, well, how many people do you have sex with today, in the last 24 hours or something like that, it's better to have somebody say, well, so glad you're here. I know you have a story to tell, and I'm really looking forward to hearing it. And along the way, I want to make sure that we think about health issues so that we can help you in some of the ways. So when you tell me your story, please include some of the ways that you knew you wanted to get help while you were here. But don't forget that we're trying to have an ongoing conversation in the clinic here. And what we can't finish today, we'll get together and talk about sometime soon. So in terms of trying to develop an ongoing relationship with people that are just exploring their lives and have all sorts of disjointed pieces, you can try to help piece it together. And it's an exciting journey that a physician can be part of, particularly with young people who are building lives from sometimes scattered pieces. I don't know if that's making any sense with what I'm saying, but for those of you who have talked with LGBT people in the office or whatever, is there anyone that has any experience that sounds like this? Louis?
All right, I'm a physician, started as a pediatrician, switched to child psychiatry and adult. And one of the things I feel very weak on, I've been in this field for 45 years, and somehow the evolution of transsexualism has escaped me, so that I'm using some of my old ways of thinking in approaching gay people and realize it doesn't work for transsexuals, especially when you're getting into hormone therapy. And now we have the political reaction to all that. So I've worked with transsexuals. I worked at the prison for a while, but they've already made the decision. I've always wanted to work with someone who is just beginning to explore and what goes into the thinking. So this isn't probably the place to do it. I'm just telling you where I'm at.
Oh, I think that's very interesting. I think a lot of physicians are experiencing that, and it's very exciting to hear these conversations that have been hidden for so long. Many young people have clubs at school or circles of friends where they can talk about it, and that's how they come up with the most clever names you can imagine. And it's just really exciting. And I don't know if everyone in their lives are excited about it as I am, but they probably aren't. But I think that we can really be a great experience as a physician to be part of their supportive environment.
I like one of the things you covered, how these people survive histories that were awful, especially when I worked at the prison for 2 years out in Lorain County, and I'd hear some of the stories. It doesn't always involve sexual issues, but a lot of abuse and neglect. And they've taught me we humans can be quite resilient if we allow ourselves to, and hopefully don't go the route of suicide and destruction. But people do bounce back, but they need support. And a physician such as yourself sounds like a good person to offer that.
Well, that's so nice of you to say that. I think that's really one of the most important insight that I've come up with in this kind of work. And the other is that the wisdom of young people is, I think, foretelling the future. Why would we all have the same gender? It doesn't make any sense. There has to be a breadth of gender, but we don't have the words for it. Maybe there were words for it long ago, or maybe in other languages there are. I hear in some cultures there are multiple genders, 8, 9 different genders in some native languages. I've heard this before, but I don't have any direct knowledge of it. And I think, well, why shouldn't we talk about that in a doctor's office? So I do. And when people come in, they'll have more ideas of things that they've read. Oh, somebody has a hand up. Maybe they want to say something.
Sure. Hi.
Oh, hi, Kristen.
Yeah, hi. I'm Kristen Kranz. I'm also a family physician, also with Metro Health, but only for the last year and a half. So you probably don't know yet.
Nice to meet you.
COVID and all the everythings. But I just thought I'd share what a blessing it is to learn from our youth and just the change in how we're thinking. And I'm lucky enough to be experiencing this firsthand in my own family, as my oldest has declared themselves, non-binary, changing their name, and we're all learning to say they, them, their, and her 3 younger brothers correct me and my husband all the time. And I'll just say that it's easy for me in the office, and it's a little bit harder for me at home. But that's 28 years of calling them something else. And so it's a great transition. And I really appreciate your attitude. And I like the idea of congratulating everyone's successes.
In the Native American culture, there is a third gender, and it's called different things, but it generally is called the two-spirit person. And because they don't know, they're part male, part female. So you're saying in a lot of different cultures, there's a lot of different words for it.
The English language doesn't have very many words, but
No.
but now they're beginning to be devised. Non-binary, I think, is at the top of the list, but there are other words that people do use. Trans masculine, for example, is pretty common, and demi boy, all sorts of things that people say. And I think that they're probably words that are used amongst their friend circle that they don't use in the doctor's office.
It goes as far as, like, I think straight women are considered cis or something.
Oh yes, cis as opposed to trans. That comes from chemistry. I know we probably all studied chemistry. You have cis bonds are on one side and trans bonds. Trans are on the opposite side. That's where that word comes from, I believe.
So yeah, it gets really complicated for us old people. We're like, wait, we understand there's a lot of different things out there, but it gets really complicated trying to follow it all.
I think in medical school, we're told to conduct interviews where we collect information, sort of like it belongs to us or something like that. Then we write it all up and then we say there's a diagnosis and all this. And talking with transgender people has made me realize that that is not the way to look at it. I try to think of the medical interview as a way to understand, but not to write down every word. And I will learn from each person, and then I'll take little tiny notes and I'll try to piece it together in a supportive way. But I try not to be highly critical and fit what they're having to say into my own frame of mind as much as I can. So people will say surprisingly horrible things about that they had a father who was drunk and then their mother killed themselves. Terribly violent, terrible things that people have experienced. That and I don't know if it's because they finally come to a safe place at the Pride Clinic where they can actually talk about these things. But it's amazing how many you actually hear. Fortunately, we were creating a team of psychologists and this sort of thing, and they have a trans wellness group that meets twice a week at the LGBT Center, which is fabulous, and it's run by a very skilled woman named Taj Hussein. She has an agency specializing in LGBT health and trauma, and then Metro Health also has hired some psychologists, Dr. Alto. There's a Dr. Smith in psychiatry who's written some wonderful, and Dr. Banuska, also from psychology. There's a team of some remarkable people that are building expertise in this area and helping people to get what they need. So if people are on hormone therapy, maybe people know this, you have to be on hormone therapy for 6 months or a year, and if you want to have surgery. So surgery for trans men includes mastectomy, which is removal of the breasts. And most people want to have them removed completely. Every once in a while, you run into somebody that wants just a little bit removed, and nuanced sort of this whole idea of body dysmorphia. Is that the right word? I think so. And so you might run into people that have specifics, but most people want to have removal. In order to have that done, you have to have a letter from a psychologist that says that you are a sane person, that you know what you're doing, and that you thought of all the pros and cons. There's no other surgery you really have to talk to a psychologist about. I mean, if you were a cis person and you wanted to have your face completely remodeled, you wouldn't have to see a psychologist to have that done. But for a transgender person, you have to see a psychologist and get them to approve it. And if you want bottom surgery, so let's say you're a trans man and you want to have a new vagina, which is not impossible to do, to sort of invert the organs and this sort of thing. You have to have 2 letters from psychologists saying that you know what you're doing, because I guess this heterosexual society is really trying to preserve the genitals of other people. Anyway, I hope this goes away, but so the International Organization for Gender Physicians still support this idea, but I hope they'll get rid of it and say, well, or maybe it protects somebody from having an idea that they forget later. I don't know, but there's a lot of hoops that have to be gone through.
I'm going to break in here. I thank you. I think I could listen to you and the many sides of this you're presenting that I've not ever heard before.
Oh, well, good.
I appreciate hearing what you have to say. Our next presenter, and we can have more discussion about this at the end. Our next presenter is Alicia Roberts. Alicia Roberts is a program coordinator who works with LGBT elders and transgender and non-binary individuals to provide education, resources, and connection to care. Alicia believes that all people deserve care and compassion no matter what their age, gender identity, or sexual orientation. Alicia was born in Akron, Ohio, moved to Cleveland to attend Cleveland State University. Ms. Roberts holds a BSW in social work with a minor in nonprofit administration. She started as an intern at the LGBT Center in older adult programs and found herself deeply passionate and invested in her work. Please welcome Alicia Roberts.
Hi, everybody. My name's Alyssa Roberts. Like it was so kindly stated, I work at the LGBT Community Center. I work with our older adults, 50 and older, and then also with a little bit with our trans wellness group with Taj and Divinity, with our transgender and gender non-conforming individuals. So I just want to talk a little bit first about our programming at the center. So our program right now is called Sage Cleveland. Stay tuned for a new name soon. But we are a group for 50 and older LGBTQ identifying folks and allies. And we have a number of services and activities, but the main point is just to get folks out. And together we have coffee in the morning, and some folks just play games. And it's just a great place for people to meet and get people out of isolation and out of their homes. We also have many exercise classes, and a group called NAMI comes in every other Wednesday. It's just a great place to get together and meet folks. I do want to share a few stories about folks that I have seen their lives transformed from coming to the center, and as well our programming too. So one individual that actually specifically comes to mind came into the center, had always lived not far. We moved into a brand new, big, beautiful building. So if you haven't stopped by, definitely do. Anybody will give you a tour, and it's a great space. It's open Monday through Friday, and you can find our hours online. But folks are welcome to hang out as well as attend our different community groups and events and our programming as well. This person lived down the street. We used to be located across the street and had lived down there for a number of years and never came into the center. They came in, were experiencing some food insecurity as well as some health issues. This person is retired, was not able to collect much off Social Security, had some other issues, and didn't was not able to work, so didn't have any health care either. So was experiencing a couple of multitudes of issues at one point. One day walked into the center, met one of our staff members and just kind of like talked about what they were going through. Our facilities director who she met, talked to this person, told them about our programming, gave them a lot of resources around the area, also talked to them about our Pride Clinic and different ways that they could get healthcare through different avenues. And they started coming to programming, and that person is now in a stable relationship, has, many friends that they see, and just has a place that they can come to whenever they need something or just want to be in community. And I think that that is so important to just see the growth of that, and just to show that, we have plenty of resources, and it can really just change people's lives, because a lot of these resources are really hard to find, especially for LGBT folks, older, don't necessarily have retirement or are still living in some sort of poverty. There's not a ton of resources, but we've done our research, and, we have a lot of community partnerships, and, we're able to give folks the resources that they need to be able to survive. And I think that, just allowing a place that's safe and quiet. Most of the time, my participants are definitely rowdy, but a place where you can meet new people and do things. We also do trips sometimes. We, a couple months ago, visited the botanical gardens. We have picnics and things like that. And it's just a space for people to meet. And I think that having that space is incredibly important. The center has always held space for folks in some capacities. The longest running space that we've held in program, it was called the living room. And in the center today, we still have something called the living room. And as a younger, I'm about to be 23-year-old queer individual, I think this story is one of my favorites for sure. And we way back on 29th Street, we had a very small center, and we held space for HIV and AIDS folks diagnosed. And it was just a space for them to come and meet and be in community. And since then, every place that we have moved to, we've had a living room. And I think that it's really cool because, sorry, I have 3 animals running like crazy. I think it's really cool because our youth primarily uses that space now. So I think it's just really cool to show the intergenerational aspect there. And then speaking on my own experience, I graduated with my bachelor's in social work from Cleveland State in 2021 in the spring. And as it was said, I was an intern for the center before that, throughout my last year at school. And all before that, I wanted to work with youth. I wanted to work with specifically homeless LGBT youth. Never thought I would work with older adults. And I started working with this age group. And I fell in love with the compassion that they have and the stories that I heard. I get to hear some incredible life stories every single day that I talk to somebody. And I think that is a huge honor and a privilege of mine that I hold very dearly. And I think it's so cool because I am a almost 23-year-old queer individual that is working with older adults. And we have the best relationship, and it gets rowdy and crazy, and I absolutely love it. And I just think that is, that just goes to show that older queer adults and younger queer adults, we're all human. We all have the same issues in some capacity, and there's a middle ground to everything. And I think that that's we're always learning, and we're all human. And I think that that's just really cool. But yeah, so I guess that's all I really had, unless anybody had any questions for me.
Yeah, I just wanted to ask, do you guys reach out to area high schools to let people know you exist? Because I was just thinking to myself, there might be some youth that are troubled and trying to figure out their what's going on, and they don't
Yeah, absolutely.
they probably, if they knew there was a place they could go hang out, that would be great.
Yeah, so we have a wonderful program at the center called QU. It stands for the Queer Youth Initiative, and that is for kids, young adults, 11 to 20. And they have a drop-in program as well that meets Monday, Wednesday, and Friday from 3 p.m. to 7 p.m. And they actually, in some schools in the area, have started running their GSA programs. So we have some partnerships with some high schools in the area, as well as we do push out to all of the local schools in the area. So, yeah. I don't know if Susan had something or.
I have something.
Okay, go ahead.
Like you, I grew up in Akron,
Mhm.
so we have something in common. I also have evolved from child work, pediatrician, child psychiatrist, to geriatric.
Awesome.
And I'm involved with a national organization, American Association for Geriatric Psychiatry,
Mhm.
and a LGBT subgroup has gradually developed since 2005. One of the things we would talk about is the loneliness factor. It can happen in any age group, but particularly harder when you're older because mobility becomes an issue. Some communities, especially large, have developed a program where an older person is adopted
Mhm.
by a younger person, not necessarily a kid, but
Mhm.
a younger adult. And I always feel it's helpful to reach out. Some older people are resistant, of course, to that, but I think you described some ways to get people involved. And even
Yeah.
if involved a little bit might grow to a next size.
Yeah, no, absolutely. I think, especially during the pandemic, I know with the people that I saw regularly attend our group, and just seeing, we would have Zoom check-ins every once in a while, and we would do our, like they do Tai Chi. So some people were doing that over Zoom and stuff. But I think that, having a place to be able to come out of isolation, and we have volunteer opportunities, so people come out to different events, and even if they're volunteering for 2 hours, and they can stay for the rest of the event and see what's going on. And I think having places like that for people to go is really important. Absolutely.
Susan Green.
Yeah, Susan.
Yeah, so I was just wondering, as a segue to Dina's question, what your outreach to older people is.
Mhm.
I live 3/4 of a mile from your center, and there's a lot of people in the community. I'm part of a Cleveland West Side Village, which is older people trying to help each other stay alive, basically. But so what are your outreach to older people? Thank you.
Yeah, absolutely. Beth, did you have a question, or did you want to help answer?
No, I was just going to comment on that.
Okay. Do you want me to go first, or you go first?
You can go first.
Sick. Yeah. So we are constantly in active recruiting for new partners. So I know right now we're creating a pretty good partnership with the Cove Community Center, which is over in Lakewood, as well as we do have a good partnership with the Cleveland Department on Aging. And so we help each other push out our literature, and we have a monthly calendar as well. We also we aren't currently, but we did used to go into nursing homes pretty often. But for a while, because of COVID, we weren't able to do that. So my co-worker, Mary Beth Bartholomew, used to be making those calls, but she's been dealing with some personal stuff. So we've had to put some stuff on hold. But, you know, we also go out into, we have a monthly newsletter. We also have a Facebook group, an email list, things like that. And we also have plenty of upcoming events that we are going to be tabling at. So we'll be at the Tremont Arts and Culture Festival for 2 days to, you know, talk to people that come up and see our table and, you know, give them literature and, you know, talk to them about what we do, as well as there's another couple events coming up as well.
So that's really fabulous. And I love what you've been saying. And maybe, you know, we'll have you come and speak to the Cleveland Westside Village.
Yeah.
And so how do we get the newsletter?
Yeah, so once I'm done speaking, I can send, I'll write it down so I don't forget, but I can send a link to sign up for the monthly newsletter through the LGBT Center. And then I can also put my email in the chat too once I'm done.
Excellent. Thank you.
My turn?
Beth, should we-
Yeah.
Okay. So some of the things they do at the center is on Monday, Wednesday, and Fridays, we get together from 10 o'clock in the morning. On Mondays, we have art therapy after we get together. They have chair yoga. They serve us box lunches. We also have one of our people send out a little newsletter, and they go walking at the zoo on Thursdays if the climate is good, or they go walking in Lakewood Park. And then once a month we meet for a breakfast. If you're in Old Brooklyn, it's called the Old Brooklyn Croons, and we get together for coffee once a month. So there's lots of in-house activities and creating out-of-house activities. Like she said, we went to the botanical gardens. We're going to be tabling with the Cleveland Center on Aging, have a booth there. One of the stories I like was we have an older gentleman there, and he only had a cane, and one of the people that goes there worked to get him a walker. And that was really cool. And he was all surprised. He didn't know he was getting it and stuff. So we kind of take care of each other and check in on each other when we're there, you know, making sure that everybody's doing okay. We had a gentleman that was doing something overseas, and he fell and he broke his knee, and he had to come back to the United States. And he's been having several surgeries with that and stuff. So we're trying to support him and, you know, keep up with him and stuff. So, and I've only been there a year, and right from the start, I felt welcomed, and, you know, I just felt welcomed, and it was all good stuff, and it's great to gather at.
One more question or comment from Nancy.
I just wanted to ask Alyssa, we spoke a couple months ago, and you mentioned a difference that you saw or have heard through stories of how older people felt about accessing healthcare or going to a doctor, for instance, and as opposed to younger people. I was just wondering if you might want to comment on that.
Yeah, absolutely. So when I see older adults trying to access healthcare, there is a large story behind that, just accessing the healthcare, because folks, you know, for so long were, you know, made to be in the closet, or if they, you know, were somehow able to come out, then, you know, it wasn't necessary that it wasn't going to be necessarily true that their doctor was going to accept them or understand them. So there's a whole other host of issues when you're talking about LGBT older adults going to the doctor, because they might not necessarily feel comfortable with the doctor to be able to open up to them that if, say, they're a lesbian woman, you know, that there is no chance of her getting pregnant. So that's maybe not a question you even need to ask. But if you ask that question and then that person feels uncomfortable, or versus I think younger adults are are much quicker to correct somebody, especially if it's somebody that they might not necessarily know, and it's something that they hold true in their heart. I think that they're quicker to correct somebody instead of just letting it go by, or instead of asking them to maybe not ask that question, or fully open up with what they have experienced. They kind of they would rather roll over than have that conversation with somebody. Whereas I see that younger adults are much more willing to have that conversation, and more, I guess, open, not willing, but open about having that conversation and standing up for themselves. So
Thanks so much, Alyssa. I appreciate hearing what you said too. So it's been a good learning experience for me. Thank you. We have a panel of 3 people now. I'm not sure if one of them is here. Is Darnell Pierre Benjamin here? I don't see him.
Unfortunately, Darnell had an urgent, time-sensitive matter that he had to attend to, so he will not be able to join us this evening.
Okay.
But we still have our 2 other guests
We
that
have
Bob
our
will
2 other
introduce.
people. Great, thank you. Anika Keisha is a second-year medical student at Wright State University, the Boone Shaft School of Medicine, and Besom Pride member. I'll get it right. Besom Pride member.
My name's Monica, by the way, just so you know. But I'm really happy to be here and give kind of like a student perspective to things.
Tell me how long you've been connected to this community and what you think it has done for you and with you.
By community, do you mean the LGBTQ community?
Yes.
Okay, just wanted to make sure. Yeah, so I realized that I was gay back in high school. I was like 16 at the time. And then within the last couple of years, realized that I also identify as non-binary. So I use they, them pronouns, and now tend to label my sexuality more as queer, just because lesbian feels very kind of box in. So for me, it's kind of been an evolving thing over the years, and my identity within the queer community has changed in that time.
Beth, you were also on this panel. Beth Shoemaker, you spoke already. Beth, SAGE participant in Cleveland. She is a group which provides advocacy and services to LGBT elders. You've already spoken about that, and do you have anything else you'd like to add?
Alyssa does a wonderful job. I've just been here a year in Cleveland, and I moved here specifically with in mind getting a hold of LGBT people, because I lived out in the middle of North Carolina, in the middle of no place, and I needed the fellowship. And that was one of the big conditions. And I came right at, well, just about a year ago, so at the end of COVID, so I could be with people that were of my orientation. I'm a retired special ed teacher, and I have a grandson who's transitioning right now and getting ready to go to Cincinnati College.
Good. I have a couple of questions for the 2 of you, and I'll put those out there first, and maybe it'll lead to some other discussion. What story of medical discrimination, either personal or in some way, were you ever witness to, or would you like to share? Have you had any personal experiences, or have you heard of personal experiences that others have had with medical discrimination?
You want to go first?
You're sure I can. So I've actually been pretty fortunate with my own healthcare. I have really just recently gotten with my student health insurance, had access to healthcare because wasn't something that I necessarily grew up with. I come from a poverty background. So having access to that now and trying to get the healthcare that I do need, have had really positive experiences down here in Dayton, which I'm very fortunate for. However, that being said, I know that that's not the case for everybody else. And in both knowing people in the queer community and also having worked in hospitals and seen interactions with coworkers and other people, I have seen some incidences of discrimination. And I feel like one that kind of hits home to me personally is purposeful misgendering. And just people, I've watched doctors or nurses or other medical staff essentially tell somebody that they're wrong for identifying how they identify and continually misgendering them using a dead name. And that's always something that's really hard to watch happen. And so as I've gotten more comfortable in speaking out myself, I try to, but there's also instances whereas as a student in healthcare, I do worry that like at some point there's gonna be a point where it's gonna be a higher up, my attending or whoever, other people, and try to be that change within medicine that I want to see while also, not getting pegged within my program. So I think that's the side that I've seen.
Mm-hmm. Beth, do you want to add to that?
Sure. I am a veteran, and so I go to the VA, and they need to put a third box for he, she, or them. And always when you say you're a lesbian, they go, "Oh, okay. I don't know what to do with you." It's not like you really have to do anything. And the thing about the, when was the last time you were pregnant, or are you going to be pregnant? I'm a 68-year-old woman. I just don't think that's going to happen. And, so there's a few, I do give them kudos. They do have a trans section office at the VA. They do have some things going on, which is great, but they're specifically focused on the trans and not the lesbians and the gay men. So they've got to balance it out a little more. But so it's one of those things where you're constantly correcting and, asking them maybe to write this down instead of that, or something like that.
If you came to my house, you would find marbles rolling all over the floor. African Americans and people of color often report being profiled by police and watched closely by white Americans. Do you experience similar discomfort in your daily lives because of who you are?
No, as a whole, for me, I'd say no, but I'm not out in public a whole lot. And I don't, other than my haircut and my earrings, I probably don't look like anybody else. So probably not.
I think for me that initially when I only identified as a lesbian, it was very like, no, like, I might dress more like a tomboy, but people didn't necessarily, that wasn't the first thing they were noticing. However, since coming out as non-binary, there's definitely been a shift in how I dress and, my hairstyle, that kind of a thing, that is definitely more ambiguous, and gender, I think that's very much more visible than sexuality is. And so I think additionally, like I have a pronoun pin that I wear on my white coat and that kind of thing. So it's something that people do tend to notice right away now. And there's some, again, with misgendering is my personal experience. There are some people who, have seen the pin, have mentioned, like that I am non-binary, and continually purposefully misgender me. And I think that's really been the big negative experience as far as like from, strangers, people that I don't necessarily know very well.
Do you think it's a generational thing though? Do you, because like from my generation, it was yes, ma'am, no, sir, and we've sort of grown out of that with the younger generation. Do you think it's generational?
Yeah, so I think there are definitely going to be people that, they make mistakes and it takes them a little while to get the hang of it. And that's one of those things like I'm totally fine with, I understand I make mistakes too. I've misgendered myself. But it's definitely one of those things where you can tell when people are purposefully like enunciating she, being this girl. So like it's that kind of stuff where I don't think it necessarily falls into a generational thing or not understanding. I think it's very deliberate action,
Yeah.
Okay, I'm going to open this up to everybody to ask questions, and we're going to alternate between a question from the chat and live, if you want to ask it on live, using the raise hand checkbox in the reactions. First, I'm going to take a question from the chat. Dana Margulies is going to sort those. And do you have a question from the chat that you'd like to share, Dana?
Well, it seems like there's not a lot of questions, but there are a lot of comments. So there's comments about terminology, like don't use the word transsexual, say transgender. Let's see what else. What cis means. Cis is presenting as the gender you were assigned at birth. It doesn't mean you're straight. So I think there's, me included, since I'm old, anybody that's old, we don't really, we weren't brought up with all this, so it's kind of foreign to us, and we're going to make a lot of mistakes. That's what I feel like. I'm trying to learn, but I'm a doctor too, by the way, but I think a lot of it is generational, because I think I see a lot of college students and young people, they seem to, they seem to be more understanding of all the terminology versus us that are in our 60s, or whatever. So we're trying to learn. Yeah, and then there's somebody that was talking about pronouns and trying to educate employees at Metro Health about what pronoun to use.
Yeah.
So there's things written about that. And then there was a statement about you have to be diagnosed with gender dysphoria so that the insurance company will pay for your therapy. That's why you have to go see a therapist. So, like what Doug was saying, that it's kind of crazy. You have to go see a therapist to diagnose you before you can get treatment.
I'm going to go to Alyssa, who has her hand raised.
Okay.
Alyssa?
Yeah. I just a comment that I think that is just an important across the board, no matter who you are, is just that when people, correct you or, try to educate, I think it's important to make sure that you're not taking it in a personal offense, because I think the only way that we're going to continue to move forward and to respect people and their own ideas of who they are and who they want to be is that we keep talking about it. And I think, as Annika, is that it?
Yeah.
Okay, just want to make sure I was pronouncing it right. As they said, it's okay to make mistakes, and we all understand them. We're all human. But as long as you're continuing to ask questions and trying to uplift others and make sure that you're doing the right thing and just constantly checking yourself, I think that's the only way that we're ever going to move forward. So Yeah, just from any stance of like if we're talking about discrimination in any forms, I think it's important to just remember that it's never coming from a personal offense. It's just a way to continue to educate and continue the conversation forward.
But I think what Annika said was, there's difference between people like me or somebody else who's trying to learn and we make mistakes.
Right, absolutely.
Versus somebody who is doing it on purpose.
Right, absolutely.
They don't want to learn and they don't believe in, there might be somebody for religious reasons. They don't even believe in people being gay and lesbian. They think everybody should be, you know what I mean? So what I was wondering about was, like, let's say a doctor or somebody, you go to see a doctor and they have some religious belief that you shouldn't be LGBT. Do they ever offend people and refuse to take care of them? I wonder about that sometimes. I mean, do you ever have anything like that happen to you?
Yeah.
Go ahead.
I was just going to say, in the VA system, I have run into a couple of diehard women are supposed to be in the kitchen having babies and men are supposed to be at work kind of attitudes. Yeah. You either find a different doctor, write a complaint, or work with them.
Mhm.
Yeah, and I think that's something important to note too, is that it's hard for a lot of LGBT identifying individuals to find somebody that they trust, because of years of trauma and generational trauma and all that kind of stuff. Like, it's hard for people to be able to open up to folks when a lot of the time, that's the response that they're going to get when they do try.
Yeah. Corinne Stat.
Hi, I was wondering, disclaimer, Annika and I are very good friends, but I do know a little bit of their story and was wondering if you'd be comfortable talking about your experience trying to find inclusive healthcare providers and how your therapy and everything has gone into that process here in Ohio.
Yeah, so I just, like I said, recently got access to healthcare that I could afford. And so it's kind of been a learning curve for me, which is, ironic as a med student that I had to learn how to get doctors and find people. But I got really lucky with my PCP. He turned out to be a great guy, very supportive, like asked me my pronouns first interaction I had with him. And shortly after having my first appointment with him, I realized that top surgery was something I wanted to pursue. And so have been on the road of trying to figure out how to do that. And going through that whole process of, getting a therapist and having my therapist, needing to write that letter to say, yeah, this person's good for surgery. They can make a sound decision for themselves. And so I luckily was able to find a therapist that I have been able to talk to and has been very respectful of everything. And so he had to, in order to write a letter, had to not only hit all 15 things in the requirements that they have for these letters, he also had to then show it to his supervisor, who had to give it a stamp of approval. And so and then they could send it to the person that I found for my surgery. And so it was like a whole, 2.5 week process to get a letter saying, yeah, they're good for surgery. And then in terms of trying to find a surgeon, I had to, luckily in being at BSOM, I've met some different providers who have connections to the LGBTQ community. And so it was a combination of reaching out to my PCP and saying, hey, do you know anybody who does top surgery? And then reaching out to those people at BSOM. and then trying to vet the people that they found, and trying to find people who are surgeons who are outwardly very LGBTQ positive and supportive, just from what I could find on them ahead of time, because I wanted to really dodge that experience of having a negative interaction with a provider who, you know, wasn't going to be respectful of me and my identity. So I spent probably a good like 2 months trying to find a surgeon, and eventually settled on one in Columbus. So I'm going to be going, you know, an hour one way just for appointments.
Bob Ream.
I'm not a primary source on this, but I wanted to mention that there was a piece of law that passed in Ohio earlier this year that allows a physician to refuse to give treatment if they disagree for religious reasons. I'm not the primary source, but I remember that. I'm hoping that somebody else in this discussion is more familiar with it than I am, but I wanted to mention it because I heard some uncertainty like 3 or 4 questions ago about that.
Anybody want to comment?
I know a little bit about it. The Ohio State legislation did pass that bill. And so that was, I know, a big concern within the medical community, to kind of green light discrimination on the basis of gender and sexual identity. And there's been a lot of discussion in a number of different areas about how to combat that. I know that there were a number of groups that were looking to try to get that repealed. But you know, legislation's a slow process, so haven't quite gotten there yet. I'm not sure what else might be in the works locally, though.
Okay. One last question. Anybody have a question for our panel?
Yes, I do.
Okay, Beth.
Is there any kind of central resource that says these insurance companies cover top and bottom surgery? These insurance companies don't cover it. You know, is there any resources that people can go to get this kind of information? Like, do we have a central list or something, I guess?
I would just say you might want to contact UCAN Ohio. UCAN, UHCAN, if you know them already. They may have they are the I would say the navigators of the Affordable Care Act in the state, and I would recommend contacting them to see if they have that kind of information. If anybody has it in the state, they would have it.
My other comment was, I've had, you know, where they're training young physicians now to ask your preference of pronouns, and they're like, oh, this is another thing for us to ask you, another thing to learn, and they can be quite rude when they're asking it. Mm-hmm. And I've had that happen to me, you know, because it's like, oh no, another thing. But,
can't handle another thing.
Another thing. So
I appreciate the speakers tonight, and you've all been really wonderful. And this has been a very, very fine encounter with you. Thank you so much for being here. I'm going to conclude this meeting tonight with a little explanation of SPAN Ohio and who we are and what we've been trying to do for 20 years. We've been around for 20 years. We are a volunteer organization that is trying to gain access to payment for healthcare for all necessary services. Could you put up the first slide, Amber? The mission of, put up the second slide. The mission of SPAN Ohio is of the Single Payer Action Network Ohio, is what the SPAN stands for, is to educate the citizens and legislators of Ohio to the need and to advocate for fundamental change in the payment of our healthcare system so that all residents have affordable access to healthcare through a publicly funded, privately delivered, comprehensive system that fulfills the basic human need for the right to healthcare. So we believe that healthcare is a human right. SPAN Ohio is a all volunteer organization with about 150 active members and about 3,000 associates from all over Ohio in our database. The second slide, the Ohio legislation that we support in the Ohio House is House Bill 446. And in the Senate, it is Senate Bill 253. These bills need to be renewed every 2 years because once the term is over, they have to be set up again. And so they have a new number each year, or each 2 years, every 2 years. Federal legislation is improved and expanded Medicare for All. It is encapsulated in House Bill 1976 and Senate Bill 4204. There isn't much difference between all of these bills, or the bills, except that the House Bill 1976 is the only one which has long-term care in it. That wouldn't be hard to add to the other two bills, but that for now is the only one that it's in. Next slide. Features of federal and state legislation. These bills cover everyone in the state or country for life. In other words, you don't have to go out every year and try to find another insurer. You are covered, period. That's pretty remarkable, isn't it? These bills provide everyone with comprehensive healthcare services, actually for all necessary healthcare services. They include diagnostic, treatment, and rehabilitation, include hospital services, prescription drugs, women's health, mental health, substance abuse, dental, hearing, vision services, etc. And that etc. is a long one. You know, hospice care is in there, for example. So they do cover the waterfront. Next slide, please. They would pay 100% of the cost of care. Think about that for a second. 100% of the cost of care. In other words, you would never see a medical bill. You physicians out there, those people in your office who are doing medical billing wouldn't need that kind of job anymore. Sorry to put them out of work, but they would not be needed. They would not have to be billing individual people for your services. So that's a remarkable feature of this, 100% of care, no co-pays, no deductibles. There would be no cost at the point of delivery of care. If you needed to go see a doctor, you could make an appointment and you wouldn't have to worry about whether you could pay for it or not. Would that be a leg up or what? You could choose any doctor or hospital. Go to the person of your choice. Any healthcare provider who is licensed. That's a remarkable thing. Next slide, please. The benefits of this legislation is really, truly remarkable. These are what I call the freedom slides. And I can read through a few of them. I don't want to spend the whole time. There is freedom from and freedom for, or freedom to. You're free. You will be free from the cost due to accident or injury. You'd be free from the fear of seeing a doctor due to cost. You'd be free from the loss of a hospital. When you go to a rural area, these hospitals are struggling because they can't get paid by everybody because there's so many uninsured people. So the hospitals would be sustained in this. They would be sustained. People would no longer have to fear from losing their health insurance, monthly premiums, co-pays and deductibles, out-of-pay network providers, surprise billing, medical bankruptcy. Medical bankruptcy is 63% of the bankruptcies in the country. And that's almost equivalent to the GoFundMe attempts that people try to get money in order to pay for bills. How crazy is that? We're the only country in the world that does that, GoFundMe for medical bills. You would have freedom to receive any necessary care. You could choose any doctor. You have freedom to choose any hospital. You could plan for a child. You could see any doctor for an unplanned pregnancy. You could give birth to a child. You could have medical care for your child. You could continue your education. You could continue your education because healthcare requires a lot of expense, and you would be able to have disposable income. You could start a business. You could move medical practice to desert areas, you doctors. You could go to places that don't have a doctor and set up your own little store and receive the same compensation because everybody who comes in the door is a paying customer, if you will. You could see more patients. You wouldn't have to be playing mommy may I with insurance companies. You would all have more disposable income. Okay, how would we pay for this legislation? Publicly funded means taxation, as we do for public services, including water and sewers, schools, fire departments, and police. And we also pay the same way for Medicare, Medicaid, S-CHIP, the VA, and Indian Health Affairs. And they make up 60% of all the healthcare provided in the country. So it's not that much of a stretch to do Medicare for all, but it would be a taxation. Next slide, please. Taxation would be less than the current premiums and out-of-pocket expenses. Price negotiation with medical providers will reduce costs by about 20%. Public schools, state and county and city governments will save money needed to improve public services. I was kind of driven up a wall by the strike in Columbus for the teacher strike to begin the year. And I sent a comment to somebody who was involved in it, and I got slapped down because I said, how much are they paying for your health care in the system? I know they're paying 15% off the top to have a insurance company do the administration of the self-insured program that they run. They are probably spending another 15% to pay for healthcare, which takes it to 30%. People are paying out of pocket, which may make another 5 to 10%. So people are spending 40% on healthcare. That would mostly disappear. And so the schools would have much more money to operate the school system. Labor unions wouldn't need to bargain for healthcare. They could focus on working conditions and everything else. 650,000 Americans won't go bankrupt every year for medical debt. Medicare for all will reduce poverty by increasing disposable income. Everybody will have more money. One of the statistics I like to quote is, when Medicare started, 30% of seniors lived in poverty. That was 1965. In 2017, only 9% of seniors lived in poverty because they had more disposable income. That's an amazing statistic. So you'd think what Medicare for all would do for that. 95% of residents in the USA or Ohio would spend less on healthcare. An estimate of payroll deduction, if this was done by a payroll deduction, would be 11% for the federal bill and 14% for the Ohio bill, which is far less than I would estimate between 30 and 40% payroll deductions that people have and or the cost of health insurance. Estimates are that people in the USA would save $1 trillion per year on healthcare costs. That's an impressive list of things. What can you do? Contact your legislators, all 5 of them. You've got 5 legislators you can contact. 2 members of the U.S. Senate, who are currently Portman and Sherrod Brown. 1 member of the U.S. House, one member of the Ohio House, and one member of the Ohio Senate. Step 2, repeat. Repeat, repeat, repeat. Keep doing it. Keep calling. Keep writing. Learn about the legislation so that you can speak to others about it. That's a crucial thing to do. Learn about it. No, I've been with this organization now for about 16 years, and it's taken me a long time to understand what it means and what it would do for us. Next slide, please. Thank you.
Cool.
I appreciate your help and your attention. And if you have any questions about anything I said, or you want something else from me, my name and phone number are in the chat. You are a gracious audience. Thanks so much for being here, and have a good night.
Good night. Thank you.
Thank you.